suspension in CPEO are outcomes and complications. We have no financial interest. CPEO is an umbrella term used to denote any syndrome, any condition associated with chronic progressive bilaterally symmetrical external ophthalmoplegia. If isolated to the eyes, it is CPEO, but if it has syndromic associations like Kearns-Sayre, myotonic dystrophy, or oculopharyngeal myodystrophy, it is called CPEO+. The ptosis in this condition is severe bilateral and has poor LPS action, which is why a sling is the surgery of choice. But because of poor poor orbicularis function and a poor Bell's phenomenon, there is a risk of lag of thalamus and exposure, which is why a customized surgical correction is needed in such cases. With this background, we wish to report our outcomes in CPEO, where we operated patients for silicon frontalis suspension. This was an interventional retrospective study. All patients underwent simultaneous bilateral tarsofrontalis sling surgery. We used a Fox pentagon, where a silicon sling was used to was attached from the tarsus to the frontalis, and using the muscle power of the frontalis, the eyelid lift was created. This is a single surgeon outcome with standard grading measurements of ptosis, levator function, and Bell's phenomenon. Sutures, lower lid frost sutures placed in all patients, which were removed at 1 week. We had 34 eyes of 17 patients with the mean age at 56 years. There was a male preponderance seen, and the mean follow-up was 25 months. We had 4 patients, or 23%, who had a family history. The pre-op MRD was minus 1.1 mm, indicating severe ptosis, and there was a post-op MRD of 2.76 mm, showing a statistically significant increase in the marginal reflex distance. The mean levator excursion was 2 mm, suggesting poor levator action. Pre-op lag of thalamus, which was seen in 50% of the patients, was measured to be at 0.6 mm mean. Post-op, there was a significant increase in the lag of thalamus at 1.32 mm. Most patients had a fair or a poor Bell's phenomenon, with 76% having a poor Bell's phenomenon. Strangely, 2 patients showed an improvement in Bell's phenomenon after surgery. All patients had bilaterally symmetrical prominent well-formed lid crease, and 15 out of 17 patients expressed satisfactory outcomes. Pre-op, 3 patients had corneal staining suggestive of exposure keratopathy and nocturnal lag of thalamus. This number increased to 9, and all of post-operatively, and all of them were managed with topicals. We had a complication rate of 17%. 1 eye had a persistent epithelial defect. 2 eyes had undercorrection because of sleeve slippage. 1 developed a corneal ulcer, which was medically managed and healed with scarring. And 2 patients had non-resolving eyelid edema. Uniquely, we had no sling granuloma or sling exposure-related complication in 2 years follow-up, bringing our resurgery rate to 12%. This was the patient who was 64 years old, was operated bilaterally. At 1 week post-op, this was the bilateral eyelid edema that was seen, which was overhanging so much that it now encroached on his temporal visual fields. After 3 months of conservative therapy, we did a limited blepharoplasty such that it did not overhang anymore. Similarly, we had a patient this was the patient with the persistent epithelial defect, which was managed conservatively. Here you can see that there is still undercorrection, which is the norm. Now, what decides what material to be used are the elasticity, the amount of scarring it induces, and the adjustability of the material, amongst other things. The mean MRD1 in our patient post-op was 2.76. Now, the standard normative values in normal patients are 4 mm, suggesting that this is planned undercorrection, which should be the norm, especially in poor Bell's phenomenon. So, the principle in CPO remains to clear the visual axis, but to undercorrect such that there is no nocturnal lag of thalamus. For a common condition, literature is very sparse, with only 7 previous publications from 1987 to 20, with limited number of patients. Most patients confirm that most series confirm that undercorrection is the norm. Our resurgery rates are in line with most, except that of Lely et al. Family history in our study was 23% compared to the normal literature, which puts it at a very high 55%. Complications, as is been reported in literature, are in line with what is being said. Undercorrection because of not related or because of sleeve slippage or not related granulomas, corneal exposure, and contour related. That non-resolving bilateral edema which was seen in our patient has not yet been reported elsewhere. This table is from the paper by Lely et al., who had an unusually high complication, resurgery rate of 39%. So to conclude, silicon tarsofrontalis sling is safe, reproducible, and effective in CPEO, but planned undercorrection will give us optimal rates with low complication rate. Silicon, because of its elasticity and also readjustability, is the material of choice. Exposure related and not silicon material related complications are the most common. Close follow-up and treatment and management is important. Systemic evaluation in the form of dilated fundus examination, audiometry, and an ECG along with 2D echo is important to find out which are the isolated and syndromic cases. If followed and operated well, they can give good satisfactory outcomes in these patients. Thank you.
Do you anchor the sleeves to the tarsal plate? Because these are the patients where there is muscle atrophy, and most of the time, it's likely to have the slippage of the material. You said there are some of the patients you saw the slippage of the material.
Yeah.
So do you anchor it to tarsal plate?
The two patients where we had slippage was the sleeve slippage, the what case
Sleeve.
upper.
Frontalis.
But we did not it was a closed sling. We did
So
not.
there was no slippage in the tarsal plate.
No,
area.
there was no slippage there, and we did not open up the lid crease to anchor these sling to the tarsus. All were closed.
Because muscle is atrophic, and so many times it is likely that it will just go up.
But oftentimes, because the eyelid muscles itself are so weak, the pull is only from the frontalis. So sometimes it just stays there, is what we've seen.
These are all confirmed cases.
Of CPU, yes.
Muscle biopsy proven.
No, not muscle. Clinical diagnosis. Muscle biopsy, we had only 7 cases which were muscle biopsy proven.
Okay. But ideally, you should do muscle biopsy.
We have to, it is advised in all cases.
Okay. You never did any lower eyelid elevation procedure where you shift the the palpebral fissure. You elevate the upper lid, you also elevate the lower lid, so that the net sum remains the same. But the palpebral fissure shifts enough to expose the pupil. That is safer than this. And did you also do safety enhanced surgery where you would do a suture tarsography and leave it on for a prolonged time, and once you're sure that cornea is not getting exposed or the Bell's is not inversed or reversed, then you remove it in a gradual graded fashion? That is safer?
No, so I agree with the point that shifting of the eyelid is important because orbicularis thinning causes the lower lid also to go down. We did not take any lower lid elevating surgeries. In 2 patients we had to do tarsographies, but that was not a standard procedure. Most patients did not have a tarsography. The frost in most patients tended to be placed for longer such that they get used to it with very infrequent opening, but no tarsography placed and gradual release.
Thank you.
Thanks.
So, do you think that fascia lata might have produced less lagophthalmos in these cases?
Fascia lata would have produced probably more lagophthalmos because of the inelasticity compared to silicon.
Okay.